My name is Michael Day. I'm a Master of Education in Digital Learning and Leading student at Lamar University. I am also a respiratory therapist at a large Cincinnati hospital. Got my first degree from Lamar University in respiratory therapy, and it served me quite well. I continued my education in respiratory therapy and received a Bachelor of Science from University of Cincinnati as well. And now here I am in a master's program because what I'm truly passionate about is teaching. I have a lot of experience. I love training clinicians, future clinicians and current clinicians, that being respiratory therapists, nurses, ED techs, and patients. I am passionate about teaching disease education. What a respiratory therapist does is all things with asthma, chronic obstructive pulmonary disease, bronchitis, pneumonia, heart problems, sleep apnea. We have quite a wide array of skill set. Teaching patients about their disease is a primary thing because it helps keep them out of the hospital. As you know, in the country we have insurance problems, and many people use the emergency room as a primary care physician, which costs a lot of money to insurers, the patient, the hospital, and is a drain on the system overall. So if we can get great patient education to an asthmatic on how to use their medications, inhalers, and clean their equipment, and what are their triggers, that can help them lead a better life and help the system overall by keeping them out of the hospital, keeping them from missing school and missing work. Next question is, what are my core beliefs about the digital learning and the input I hope to make in my organization? I typically teach with PowerPoint presentation, go slide by slide, and then do some hands-on. Oftentimes I'll give nurses, if we're all gathered in a room, I'll get a discussion going and actually get their voice out there. What are their fears? What are their beliefs? Why are they resistant to a lot of nurses are resistant to the training because they believe they can just call the therapist. That is not good because the therapist is not at every ventilator patient's bedside 24/7. We have usually many ventilator patients, and it's the nurse that's at the bedside 24/7. So that nurse has to recognize if tubing becomes disconnected, or if a patient's changed their disease, if they got a hole in their lung, if there's any process change with the patient, they have to be able to recognize that through the alarm system setup and the volume return on a ventilator. So what I typically do is go slide by slide and let the nurses have their voice, get side discussions going on about different scenarios that they've had, and bounce that off each and every clinician. That way we can go slide by slide, so they, in my mind, have digested the slide previous before we move on to the next slide. That way it's a nice building process that's very slow and methodical. Then I follow that up with hooking up a ventilator to a test lung where we can recreate some alarm scenarios, show each and every button, each and every reading that's on a ventilator very slowly, step by step, while it's not hooked up to a patient, so nobody's in jeopardy. That is the primary way I teach clinicians. Patient education is going on all the time. What I like to do with digital learning is create an e-portfolio that I can put some of these education materials on, so that way if I educate a patient on asthma who's very sick, but they get sent home, they probably didn't digest but a portion of what they needed to. And that'd be nice to send them to a website and say, hey, Next week when you're feeling a bit better, get on that website, rewatch, a video training session, and that way they can get 100% of my teachings out there. What is right and wrong with education, and what should the world do to enhance or fix it? Education is very structured. It's by memorization and grades. And I believe the COVA model is very important. This is a new concept on me, and I love it, quite frankly. It's choice, ownership, voice, and authenticity. When I'm able to choose and own the project that I'm writing about or learning about, it makes me put much more into it, and I believe you get much more out of it. So that's the importance of the COVA model, and I think it's a great thing to start allowing students a little more freedom with their projects so that they can learn different ways to put things into it. Then we can get them to do their required work with greater enthusiasm, greater knowledge. What are the emerging issues related to digital learning at the state, regional, national, and in global context? For me, in the medical field, there's not many step-by-step instruction sites or blogs that are specific to a patient's individualized questions. Yes, you can go to WebMD, but you get very generalized information. They're very reluctant because it's medical advice per se, but that's oftentimes not what patients are seeking. Patients are seeking very specific questions like, hey, my nebulizer broke, what is wrong with it? It's just not working. Where if there's a blog set up on an e-portfolio, such as what I plan to create, they could actually type in a question like that and get a answer within a day that basically says, hey, check the Venturi or check the filter. Is the machine coming on? In different troubleshooting scenarios with pieces of equipment and different little therapies we have. Oftentimes doctors cannot even provide the information the patient needs. Yes, they prescribe the medicine, but they don't know all the medication delivery systems quite like we need to know them, and the patient needs to know them. So that's kind of where I see my e-portfolio transpiring, and I hope I didn't talk too long. Thank you for listening. I appreciate it. You have a good day.